Hola, queridas, queridos. Welcome back to the Beam and Flow podcast, a nitty gritty exploration of your body, energy, awareness, movement, and flow. I am your host, Chloe Copresi. Here we go. Enjoy the show. Buenas, queridas. Okay, so I am really excited to share this episode with you today. I got the chance to sit down with Dr. Glatter of NY Ketamine Infusions. And I have to tell you, this conversation was planned a few weeks ago. However, the course of the conversation took a different turn because of the information revealed about the cause of Matthew Perry's death over the weekend. And so there's been a lot of conversations happening around ketamine and its safety and its use and what it is and how it should be used and who it should be used for and with. So we get into all of that. This is a timely conversation. If you've been a fan of the podcast for a while, if you've been a friend of the show, you know that we talk openly about plant medicine and psychedelic therapies. And I am very aware of how misused these medicines can be and have been. And I am also very aware through experiential practice of how beneficial and life-changing they are and can be. And so I want to provide a really balanced discussion where we look at both sides because I don't think that you can make the choice that's right for you without all of the information and all of the facts. So we're going to get into it today. And any questions that you have, please feel free to put them in the comments, send me a DM, reach out to Dr. Glatter. We want to get you the information that you need and that you're looking for. So if there's anything that we didn't cover in this episode that you want to know, hit me up. Let me know. Dr. Glatter has already agreed to come back because we just couldn't stop talking. So we are going to do another episode with him at some point. But I wanted to just get started with this season. We made it a whole year. Oh my goodness. Before we get into the episode, mi gente, we made it a whole year with the show, with BEAM&Flow, the podcast. Okay. All right. I'm proud of us. I'm proud of me. I'm proud of you. I'm proud of all of us. I love doing this show. I love connecting with you in this way, and I love exploring these topics that have really been a guide for me. And if I can, through exploring them deeper, be a guide for you, then like I'm living my best life. And so thank you for being here with me for the past year. Feliz winter solstice. As always, we're starting with the new season with an astrological major event, so the solstice. And yeah, may you be blessed in this season. And I'm so grateful that you're here with me. So all that said, before I get emotional and start crying here we go with this episode with Dr. Glatter of NY Ketamine Institute. Thank you so much for joining me today. And yes, I did about you through my former therapist. I have no problem with my audience knowing that. Miles was my therapist for quite a few years. And I remember when he actually first did some sessions at the Ketamine Institute and was really positive about his experience, and then was very honest about how, given his age and where his health was, the feedback he was given when the results weren't sustained was, you may not be a great fit for this right now because of those aspects. So I really wanted to kind of get into that a little bit because I appreciated him being so honest with me about that. And I appreciated that he got that feedback from you all, from the facilitators, instead of just going into any sort of psychedelic treatment where you might not have that level of trust in who's overseeing the program. Like some people would have just said, oh yeah, let's come back for a few more sessions. It's just going to take some time to work. But to have that forthright honesty, I think, is really critical in this work. So if we could start the conversation kind of there, like, well, first of all, for people who don't know, what is ketamine
Right.
and who might it be appropriate for in a therapeutic medical setting?
Right. Ketamine is an anesthetic that was FDA approved in 1970. It's very safe. Its effectiveness has been established over decades. In fact, the World Health Organization listed it as one of the top 10 essential medicines since 1985. So just knowing that is very important. Now, ketamine found its use primarily actually on the battlefield. It was an ideal anesthetic, number one, because it did not affect respirations or breathing. And because of that, it was seen as a very safe drug. Ketamine itself, just backing up a little bit, is a derivative actually of a psychedelic known as PCP, but it's been modified to reduce what we call the psychomimetic effects, which really involve hallucinations as well as the potential for psychosis. So, by modifications of the drug, a synthetic form was developed that essentially was much, much safer. Now, again, in the mental health realm, ketamine was actually discovered by accident. Soldiers coming back from the Gulf War who were significantly depressed, who had attempted suicide, were given investigational infusions by the military, by the Army in the early 90s. And they stumbled upon its effects and started studying it very intensely at Yale and then the National Institutes of Mental Health. And what they found was that ketamine was ideal for treating depression. Um, Ketamine doesn't act immediately, it acts in a delayed fashion. And this is what they found, that people who had infusions of ketamine really in the next day or so started to feel better, 12 to 15 hours after the infusion. And by virtue of that, important research was begun essentially in animal models looking at why it was elevating people's moods. They found that it blocked a receptor called the NMDA receptor, and by doing so, prevents the reabsorption of glutamate, which is an excitatory neurotransmitter. And by blocking the absorption of reabsorption rather of glutamate, elevates essentially you elevate the level of glutamate, and that makes you feel better immediately. It also elevates an important protein called brain derived neurotrophic factor, or BDNF. BDNF is critical in order to maintain but also repair what we call dendrites and synapses, the connections between our mood centers. The mood centers that we're talking about are the prefrontal cortex, the amygdala, and the hippocampus. These three mood centers comprise about 90 billion nerve cells or neurons. And essentially, what ketamine is doing is elevating the level of BDNF, or brain derived neurotrophic factor. And by doing so, you cause an explosion in density of what we call, again, the synapses, which are the spaces between cells and how they communicate, and the dendrites, which is the lattice work of how the cells, the nerve cells themselves, are connected. That explosion of dendrites and synapses results in what we call a structural repair, as opposed to a chemical approach that medicines take, which modulate levels of serotonin, norepinephrine, and dopamine. And so, what we're doing essentially is a structural repair as opposed to a chemical approach, to reiterate. And by doing so, by having more synapses and dendrites, you're connecting the mood centers. Connectivity is what makes our mood more at an equilibrium, avoiding the highs and the lows, anger, depression, anxiety, things of that nature, and smooths out our mood. Ketamine helps to produce some distance between our thoughts and emotions, not detachment, it's not depersonalization or derealization. It's distance. And it's this distance which allows people to feel better. Feeling better is important because obviously someone wants to function better, go back to work, integrate with their family. But feeling better is really part of understanding that it's a delayed process. Ketamine does not act immediately. The experience of ketamine is calm, pleasurable, and relaxing. And that is the medicine acting during the infusion, which we typically start for the first infusion at 90 minutes. But it's important to understand that ketamine starts to begin acting 12 to 15 hours after the infusion. So actually nothing truly therapeutic is actually happening as you receive the medicine. you're somewhat passive in this. And certainly, we'll call this a lightly dissociative experience, in that you feel this calmness, this slight separation from your body, but you're in no way looking down upon your body. You're not hallucinating. It's just a very unique feeling of pleasure, calm, and relaxation, where you can be in touch with your body and your feelings. But it's important to understand that we don't want patients during the infusions, and there are 6 infusions over 2 weeks, and we'll discuss this in a second. We don't want patients to focus on any issues or pick affirmations. Basically, we want to distract patients because, again, nothing therapeutic is happening. So we want them to just enjoy the actual experience. And that means distraction with music, watching a video, listening to a podcast, maybe like your own podcast, and really enjoying that aspect. So just having and living in the moment, pushing all negative thoughts out, not focusing on issues, but really listening and immersing yourself in a medium that allows you to be distracted. And by doing so, this allows much more pleasure and obviously doesn't lead to, in my experience, any negative reactions during the infusion. So we're talking about 6 infusions over 2 weeks, over 14 days. That's our standard protocol. It's developed from research that's been done, again, in the late 90s at NIH, as well as research at Yale that was very integral, and then more research locally here, actually in New York City by major institutions. And so the first infusion is over 90 minutes. It's 0.5 milligram per kilogram of body weight over 90 minutes. The second infusion is actually the same dose, but we compress the time from 90 minutes to 60 minutes. That does increase the intensity of the feeling. And important to know that intense experience is actually a very calming experience. And we do go up on the dose in doses 3, 4, 5, and 6, only to achieve a sweet spot. That's the point at which your symptoms start to improve, meaning feeling if you're having lack of focus, lack of energy, difficulty concentrating, if you're feeling hopeless, if you're irritable, very depressed, if you have even some passive suicidal thoughts, that should start to be improving. Most people don't respond after the first dose, only 1 in 5. The bulk of people, 80 to 85%, respond after the third or after the fourth dose. So we ask them to be very patient. Again, ketamine acts in a delayed fashion, so the stacking of the doses is critical in understanding how this protocol works. And so if you haven't responded by the 6th dose, we generally stop treatment. The medicine itself, obviously, and the therapy is expensive. We understand and appreciate that. So we don't want you to, obviously you're budgeting time and money for this. So if it's not working, we have to be honest. However, if you do get a response at the 6th infusion or much earlier, then at some point in the next 4 to 6 weeks, your mood will dip. Ketamine does not act in perpetuity. And this is to your point of what you brought up earlier. The boosting aspect is essential. So it's not just the 6 infusions. The 6 are designed to see if we can get a response, improvement in mood and function. In our experience, we have an 84% noticeable improvement in data in our practice at New York Ketamine Infusions in January 22 to January 23, and noticed that 84% had at least a 20%, but up to a 50% and greater improvement in their mood and function on self-reported scales, asking patients how they feel, what their mood is, how their function is, etc. So that improvement that we've tracked is significantly impressive. Across the board, if we look at all patients we've treated, we see, this type of response. And since 2011, we've treated well over 5,000 patients. Dr. Glenn Brooks, our founder, has been the motivating force and obviously the founder of our practice. And his response rates are really superior and have really rivaled anyone else's experience in the field. Across the board, if we look at all patients, we'd see at least a 75% response, but more recently, as discussed, up to an 84% noticeable improvement. So the results speak for themselves. Now, it's important to understand that ketamine does not work for everyone. There are patients who may not respond to ketamine. That may be related to genetic factors. Research has pointed to a gene for what we call brain derived neurotrophic factor. That's the protein that's integral for maintaining the synapses and dendrites in adequate concentration in order to have connectivity of the mood centers. So it's possible some patients may not have enough copies of the gene in order to elicit a response when ketamine is infused, since ketamine elevates BDNF. So we know in mice, in what we call knockout mice, if we take the gene away for BDNF, they just don't respond to ketamine. So, in a similar way, we believe that humans have an inherent ability to respond to ketamine, and it's based on the number of copies of their gene of brain derived neurotrophic factor. Now, who do we treat? We treat patients primarily with major depressive disorders, also patients with treatment resistant depression. In other words, they've tried a few medicines, at least two medications, and they're not responding. We treat patients with bipolar depression. Ketamine works quite well for depressive phases of bipolar disorder. Bipolar 1 and 2 patients do see us. We want to emphasize that we've never, ever triggered a manic episode in anyone receiving a ketamine infusion in our practice over the last 12 years. So bipolar depression responds exquisitely well. We also see patients with obsessive compulsive disorder. We find significant improvement where other modalities have not helped, especially TMS or medications. We also see a number of patients with eating disorders. We find significant improvement in those subsets of patients, specifically calorie restriction. And in knowing that, certainly patients can try other therapies, but it's been quite effective in our view. Um, and so overall, and I should mention in addition, we do see patients with postpartum depression that don't or have not responded to traditional medical therapies, including SSRIs or other newer FDA-approved medications. So in that subset of patients, certainly women, we're talking not the baby blues, but severe postpartum depression. In collaboration with their therapist and psychiatrist, we have successfully treated with patients with postpartum depression. Very important to know this, which can be disabling for obviously mom, baby, and the family. And so ketamine has found its role really in such an important way for patients, again, with major depressive disorder, also PTSD, post traumatic stress disorder, patients who have crippling anxieties related to this, patients who have flashbacks. Now, the kind of trauma we treat typically in our practice is not battlefield trauma or, trauma from, or veterans returning from war, though we do see some of those patients. But we treat childhood trauma, patients that have parents that have fought. There may have been also a neglect. There may have been physical abuse leading to what, we'll term post-traumatic stress disorder. And this can manifest as anger, rage, substance abuse, as well as many mood disorders for that matter. So understanding everything in the sense of PTSD and understanding that as a result of a difficult childhood, whether it be parents that are neglectful, that are difficult, bullying also may play a role. There may be body dysmorphia, gender identity, sexual identity. All these things elevate the cortisol level. And by doing that early in life, from birth into our late 20s, when our mood centers develop, that elevated cortisol suppresses brain-derived neurotrophic factor. That drop in BDNF leads to loss of connectivity, meaning loss of dendrites and synapses. And the research for this is backed up again through animal models in terms of what we described just earlier in the podcast. And so all that ketamine is doing is really reversing the drop in BDNF. And by elevating BDNF, we can then form an explosion of dendrites and synapses and also repair dendrites and synapses that are not functioning optimally. And that connectivity really is the key to treatment response. And patients uniquely have responses that are specific to them. in terms of their symptoms, what they're dealing with, issues in their life. And so ketamine helps to provide that distance, that well called safe distance, where they can more easily deal with these difficult issues that have really made life quite challenging.
So, two questions off of what you just explained. One, let's say a patient has been, or potential patient has been struggling with depression and anxiety for many years, PTSD
Mhm.
um, as a root symptom or root cause, and they're on SSRIs, they've been on medication long term. Is that something that they need to wean off before they come in for ketamine treatment? What does that look like for someone who's, like, been in the thick of it for so long? How do they prep for coming in for treatment?
Right, that's a great question. And so it's important to understand that there are really only three medications where we have to have levels weaned down or to a level that's acceptable in order for a patient to respond to ketamine. There are, as first of all, SSRIs and SNRIs, commonly prescribed medicines like Zoloft, Paxil, things of that nature, Celexa. Those medicines are safe. Um, Mood stabilizers are completely safe. There's no actual really contraindications or interactions with ketamine. The only three medicines that we have to wean down are Lamictal or lamotrigine to a level of less than 150 milligrams, because levels above that can impair the efficacy of ketamine's response, um, or your response to ketamine, rather. The other major medications are benzodiazepines, such as Ativan, Klonopin, and Xanax. We want that really at a level of 1.5 milligrams and below in order to ensure optimal treatment response. The other medication is GABA or GABA aminobutyric acid, GABA. Levels above 300 milligrams can impair the ability of you to respond to ketamine. So, in a nutshell, we're talking about one mood stabilizer, Lamictal, and other benzodiazepines like Ativan, Xanax, or Klonopin, and then the third category is GABA or GABA aminobutyric acid. Other than that, there's no interactions, dangerous ones. Patients come to us who are taking, for example, Adderall or Concerta, things for ADHD. Those medicines are still safe. However, we ask them to hold them before the infusion. Sometimes they can get nauseous or their blood pressure can elevate. And that brings me to the point that in terms of who we're treating, we don't want to treat anyone as acutely psychotic, schizophrenic, anyone who's manic, anyone who's actively suicidal with a plan. Those types of patients, specifically patients who are actively suicidal, need to establish care first, be stabilized before consideration for treatment with intravenous ketamine. When their suicidal ideation is more passive, meaning that they don't want to actively harm themselves, then we consider them for treatment, but only after speaking with their psychiatrist and therapist. Also, patients with elevated blood pressure or uncontrolled heart rates, what we call tachycardia, need to have this managed prior to beginning therapy. Anyone with a blood pressure greater than 140 over 90 has to have that managed medically by their physician prior to us beginning ketamine therapy. The reason is that ketamine does mildly elevate blood pressure and heart rate, but not in any dangerous way. It would only be elevated to, say, at a level when you're mildly exercising, for example. But we do need to have that managed because ketamine can mildly increase the blood pressure and heart rate. Um, Anyone who's actively abusing substances, including opiates, cocaine, benzodiazepines, they must complete a treatment program prior to beginning therapy with us. Um, this will impair not only their response, but also can create dangerous conditions when infusing ketamine. I want to emphasize that, certainly with the revelations of Matthew Perry surrounding his death, we recommend and always have abided by in-office treatment with medical supervision as being the standard of care when administering IV ketamine. We do not condone in any way the use of at-home therapies, specifically by compounded pharmacies that do telehealth. In this setting, it's not safe. Patients aren't supervised. And so, again, I won't get into the details about what happened with Matthew Perry, But the situation certainly seems to point to possibly the abuse recreationally of ketamine, which certainly in that setting can be addictive, both physically and psychologically. And so at the doses we provide in our practice, very low doses, again, 0.5 mg/kg, which is well beneath the psychedelic dose, which can approach 2.5 to 3 mg/kg, we do not see any evidence of addiction, psychological or physical or anything in that matter. So I want to just reassure the public that the in-office use of intravenous ketamine that's monitored by physicians in our practice is very safe and efficacious. And I want to make that clear to the public.
I'm really glad that you brought that up because it's certainly something that I wanted to bring to this conversation.
Mhm.
It was something I wanted to talk about anyway, and then the all of the information around Matthew Perry came out, and it was like, "Oh, well, this is super timely to talk about." But even in my own experience, I, um, was aware of ketamine therapeutically first, and then I was friends with someone who developed a ketamine addiction, like
Mm.
true addiction, and, um I mean, I saw now this person, I wanna make it clear, has had and had addictive issues in the past, addiction issues in the past, right? This was not the first substance that they were abusing.
Right.
Um, it was very clear to me, like, what that it was so easy to abuse it, and it's something that I will say I experienced ketamine once,
Mhm.
and not in a therapeutic environment. It was I mean, I own that I made the choice. I
Mhm.
did feel pressured into doing it, and it was I thank God that, like, I was okay because it was completely under the wrong circumstances,
Mhm.
and I'm someone who has had a lot of therapeutic experience with psychedelics of all forms, so I'm very aware of how you are supposed to go into these situations, and I didn't go into it
Mm.
in that, um, intention or in that environment,
Sure.
which was already strike 1 and 2.
Mhm.
Um, and I will say that it was probably the most frightened I've ever been taking psychedelics, in that I thought I might die. I really did, and um, it maybe lasted 15, 20 minutes, and then it passed and I was okay. I mean, I was very sick, but I was okay, and I still believe in the power of ketamine treatment therapeutically. Like, I'm still an advocate for it because I've also seen it with my clients. I've seen my clients go in for ketamine treatment and have really positive
Mhm.
experiences and make big changes in their life as a result. So I just wanted to, since my podcast is we're very open about exploring plant medicines and psychedelics, I want to make very clear for my audience, like, I've seen both sides of this equation. I've seen ketamine used properly in therapeutic settings with amazing results, and I have personally seen it in my life and in people that I'm close to destroy otherwise healthy lives. And so I want to be really, sensitive to the fact that we are, as a nation, a people ripe for addiction. And I think ketamine can be used to actually potentially treat addictive behaviors through getting at the root of the PTSD trauma. Um, but again, that's a process and that takes time and there's therapy involved. It's not just the medicine being ingested. So I wanted to kind of talk a little bit about what that therapy is like as part of the institute. Like, patients are coming in and they're receiving ketamine infusions, but they are also getting therapy with it. Am I correct in that?
Well, we actually allow therapists to come into our practice if they'd like to actually, sit by the patient's side and integrate and speak with the patient. We do find that at the higher doses that we're giving, when I say high, they're still low doses, meaning 0.5 mg/kg up to 1 mg/kg. Patients their ability to recall and in other words, their cognitive aspects are often impaired during the infusion. So conducting a meaningful sort of therapeutic setting or situation is problematic. So at lower doses, sometimes what's been done in other practices, this is not what we do, but at lower doses, maybe zero point 0.1 to zero point 0.2 per kilo, then there can be a meaningful discussion sometimes. But again, retention and recall at the higher doses of what we're doing, again, when I say higher, 0.5 milligrams per kilo, the retention and the cognitive ability of patients is somewhat impaired. And so we recommend therapy to happen actually at 1 to 3 days after an infusion. And that's really the optimal time of what we'll call integration. And that's at that point that when you have some distance between difficult thoughts and emotions, where you feel better from the therapy, you can discuss things that are upsetting because of this distance that's created with ketamine. So again, it's not detachment, it's some distance. It allows things that are normally triggering or upsetting, especially difficult memories in the hippocampus or the amygdala, which is what ketamine is really doing. It's tamping down that excessive response. So it allows you, by connectivity, to have these difficult discussions. And so the therapeutic experience with, again, a therapist is really not during the infusion, it's after. And that's our belief in our practice. Now, that said, we do allow therapists to come in for support and comfort to be with patients and provide that support when necessary. But it's our belief that ketamine assisted psychotherapy really is not ideal intra infusion during the infusion. It's really the time after and the days after where the integration process is so key and critical. And bringing up a point about abuse of ketamine versus, again, the therapeutic use that we're doing, there's certainly something here to be said, especially in light of Matthew Perry. And again, we don't have all the details. There has been the ME's report that we've had some inklings of, but it looks like other substances were on board. And along with his, likely recreational use, whether it be powder or some inhaled form, possibly a spray that was compounded, we don't know this, but if there was use of powder that was snorted or inhaled, that can create an addiction. And that's commonly what we see in patients who have ketamine addictions. They've seen a physician, they've had a compounded spray prescribed, and they develop this physical and psychological addiction to ketamine. It's certainly troublesome. It could be very dangerous. And getting back to the at-home use, again, where there's no supervision, some patients may need to be talked down. They, may be in a state by themselves alone with difficult emotions, thoughts. They may not feel that they're oriented, and without that supervision, they could self-harm. They could also engage in, dangerous behaviors, and certainly which could be life-threatening. So again, at-home use, even with lozenges or troches, we'll call them, can lead to an altered state, again, without proper supervision medically, which can be exceedingly dangerous. And so it all comes full circle that, again, the at-home use, which the FDA has called attention to, and certainly regarding compounded ketamine, which we're talking about, is a valid and ongoing concern. And we know that patients do recreationally abuse ketamine. That abuse is exceedingly dangerous, and patients have to realize this. The physical as well as the psychological aspects, but mostly the psychological aspects play into this in terms of when patients abuse ketamine. And again, typically by snorting it or by excessive use of compounded nasal sprays, which are not indicated, again, for treating depression. Many patients see a physician, may have other complaints, including low back pain, and they get prescribed ketamine nasal spray, thinking that this would be a way to reduce opiate use. But the flip side of that is that it can lead to abuse if improperly used and not in the prescribed fashion. And this is what is the slippery slope surrounding ketamine. And I think the public should be aware of this.
Do you think that the um, potential for addiction with at-home use has anything to do with what you said earlier, where after you experience the initial effects, let's say in a therapeutic setting,
Right.
there's going to be a dip? When you said that, my mind immediately went to MDMA and how there is a dip after that because the serotonin is levels
Correct.
are dropping. I don't think that's the same thing that's happening with ketamine, but whatever that dip is, would that have anything to do with why it's so addictive?
The dip specifically, again, in our practice is not what we see leading to, in other words, a craving or addiction. It's just that someone's mood and function drops. And I'm glad you brought that up because, again, ketamine doesn't act in perpetuity. After the 6 sessions, assuming you feel better, you're functioning better, you're less depressed, then we know that your mood will dip. And that dip is really not, again, it's not serotonin related because ketamine works off the glutamatergic system. The dip happens really because of the lack of synaptic, what we'll call input or stimulus. The ketamine itself spurs the development of synaptic and dendritic growth, and that dip is really the sort of the pullback of that synaptic and dendritic stimulus. It's not, in other words, anything else beyond that in terms of a neurotransmitter as we understand it. And that lack or the dip is really related to connectivity kind of pulling back. That's why patients need another booster. And that happens on average 3 to 6 times a year in our practice. Of patients that complete a year of therapy, again, 6 infusions, as well as 3 to 6 boosters on average, 8 and 10 patients don't need to see us any longer because they're feeling better. Some can come off medications, but though that's not the goal of ketamine. We see medicines as stabilizing factors, such as SSRIs, SNRIs, other mood stabilizers. Some patients can come off medicine, but again, that is not the primary goal of ketamine. It's really an adjunct to medication, along with psychotherapy and support. Um, but it's important, just getting back to your point, to understand that the risk of ketamine abuse is not in and of itself due to any adverse effect of ketamine in terms of the dip that you referred to. It's a normal aspect of what we expect to happen. We don't see this leading to craving or psychological addiction in the gross sense of how you're describing it. It's really a pullback in function and mood that leads to the need to boost. And it's not a craving psychologically per se. So that's really my really answer to your question and to your audience, that we're not talking about any kind of craving after getting these infusions. Now, certainly the feeling is pleasurable, but at these low doses, we just don't see any addiction developing in our practice. And I just want to, reinstate that at New York Ketamine Infusions, we do not see addiction, again, in the therapeutic delivery of ketamine. The audience should understand that what happened with Mr. Perry is not in any way the experience that patients would ever receive in our practice. It's clear that his last infusion, according to reports, was at least 10 days prior to his death. So he somehow had gotten access to ketamine, whether it's through the illicit market, through a prescriber. It's unclear whether he had used a spray or some type of capsule that he opened in order to inhale the ketamine, or just buying ketamine itself as a powder. It's something that certainly um, you know um, we're concerned about because why did he do that? We don't know, but it's possible that again, he was looking to, have an experience. And again, we're not about the experience at New York Ketamine. Nothing actually therapeutic happens during the infusion. We don't focus on the experience. And again, I want to emphasize that because it's not about the experience. It's about really the days after ketamine when you're feeling better that you can then more rationally and pragmatically talk to a therapist, integrate your experience. It's not about what you feel and even experience during the infusion. I mean, thoughts may come in, and certainly it's okay to discuss them in a therapy session, but really it's when you're feeling better from a physiologic standpoint due to the synaptic and dendritic growth that allows that distance that I mentioned to occur and not to have a fight or flight reaction, not to feel triggered, not to feel anxious, to have a calm mood. And that's really what it's about. Um, Getting back to Mr. Perry, there were other substances found on board. And certainly in a recreational aspect, um, you know, uh, it, it, it speaks to that concern and that problem with addiction and abuse. In our practice with we certainly have an issue with at home unmonitored unsupervised use. We believe in office supervision of intravenous ketamine infusions, and that really is the gold standard. What happened in his case is not in any way comparable or in any way related to the experience of what our patients would have. So it's unfortunate, but his use in a recreational sense, based on what we know, was certainly contributory to his death. The fact that he was in a hot tub, um, the fact that he became unconscious and then drowned subsequently, was certainly related to the high levels that they found in his bloodstream. Um, but there also was a cardiac issue. He may have had a heart attack. We don't know that. That could have been a factor in ultimately in what happened. They did find therapeutic levels of buprenorphine, which is an opiate mixed opiate antagonist used in therapeutic sense for opiate addiction. But that, along with other what they purported to find benzodiazepines, could have been contributory. The ketamine itself is not a respiratory depressant. I want to make that clear to the audience. When used at levels we use in our office, there is absolutely no respiratory depression. Now, when used at high levels, such as in Matthew's case, along with other medicines on board, in a recreational sense, yes, there could be a problem. And being in a very hot body of water wasn't ideal either, because that could have changed his sense of awareness. And so we never, ever recommend patients to go into a warm body of water in any sense, in any relationship to ketamine. And certainly we don't, would never have ever condoned such behavior. But again, it's a very difficult loss for his family, his friends, the world. He's beloved, and certainly it speaks to the throes of addiction. And we're not doing enough in our country to really treat this. An article in the New York Times came out this weekend about substance use disorders, very well put together, and really laid out the foundation that our country is still ill-equipped. For example, methadone is a great drug to treat opiate addiction, but you have to go to a clinic unless you get, you know, we prescribe methadone for pain in an outpatient sense, but you can't get it for addiction. You have to go to a clinic. And that is a barrier, unfortunately, for many who suffer with opiate use disorder. Um, we know that ketamine can be used to treat alcohol use disorder, as you alluded to earlier, as well as opiate use disorder. And it can be effective. It doesn't work in everyone, but it can cut cravings. And so ketamine has found a use in the addiction world to treat alcohol use and opiate use disorder. In our practice in your ketamine, we don't specifically yet treat addiction in that sense. But anecdotally, I can tell you that patients who have used substances like alcohol and opiates have found a reduction in cravings, in a general sense, who have gone through ketamine infusions. So there is value to this.
Um, I I want to just talk a little bit about when you said he might have been looking for an experience. I think that really hit the nail on the head because even people I know who have gone in for therapeutic um, infusions, right? Um, I've known a couple of people who, after, let's say, session 4 or 5, I don't think they went the whole 6 at the point. Um, their their response was, "I didn't go anywhere. I didn't see anything,
Right.
so I don't think it's working." And I think that speaks to how people are educated at places other than New York Ketamine Institute as to, like, what and how the experience ideally should go for this type of um, treatment. But I think that people associate psychedelics with having a psychedelic experience, and that's not necessarily the case. For example, when you're microdosing psilocybin, you are not having if you have any sort of
Right.
psychedelic experience, you are taking too much and you're not getting the benefits that you would be from a microdose.
Right.
Which um, I say that to just kind of put into the audience's mind frame that to remove the idea of having a psychedelic experience from getting ketamine treatment, because they're not the same thing. Um, and while you might be able to have a psychedelic experience with a different way of ingesting the medicine or a different dose, that's not what we're talking about here. Um, and I think going back to the addiction piece, there's there's always an a mental, emotional, psychosomatic underpinning to addiction. I mean, always. And in some ways, addiction can change forms. And so I want to make it clear to my audience that, like, you can be addicted to the psychedelic experience. You can be just going from medicine to medicine to medicine to medicine, looking to have that experience and looking to dissociate or leave your body, whatever it is for you. But you're not that's not the purpose of what psychedelic medicine is. That's not what the purpose of therapeutic medicine is. It's to integrate the lessons from that container of time that you're working with the medicine, and then let it change your life. Like, do the work to make to keep going in the direction that opened up from the treatment, right? But to open up and then say, "Oh, wow, that feels great. I should do this again next month so that I stay open, or next week so that I stay open." Like, you're missing the point. That's not the point. At least that's not the point for me and for many of us in this community who are really trying to get the word out around how best to use this medicine.
Right. These are excellent points you make. I want to be clear that ketamine has been lumped in with the traditional psychedelics, but it's truly not a psychedelic as we use it. Now, can ketamine be psychedelic? Yes, if I give you a high enough dose, it can be. But that's not beneficial to you or me. We're really for treating mood disorders. And that's what I want to make clear to the public, that getting psychedelic in and of itself is not therapeutic, meaning that there's no synaptogenic or dendritic, or in other words, connective effect that's sustainable by getting psychedelic. And this has been shown in studies. It's the lower doses that are actually more efficacious for building synapses and dendrites and connecting the mood centers and improving your mood and function. So it has nothing to do with the experience, as you just alluded to. And we try to really impress upon our patient that's really the important point. You don't need to feel a certain way in order to get the effects of ketamine. You're passive in this process. You're distracted. You're listening to music. Yes, you're enjoying it, but the experience wears off in 2 hours and you're back to normal. Stays in minute amounts for 6 to 8 hours, but ultimately it's not about this experience that you're feeling. Now, that said, if people do dissociate, that's great. I mean, they enjoy it. There is some literature that does talk about that if you do have that feeling or that dissociative type experience, not psychedelic, but just dissociative, or that you really truly feel the medicine, that it indicates that it's working. And there is some evidence to that, that if you do feel it that you might psychologically be getting some more additional effects. But that said, you don't need to have that really that what we'll call rocket ship experience in order to benefit. And you don't need that. We don't in any way emphasize that. And there, again, nothing therapeutic happens during the infusion. Ketamine starts to act 12 to 15 hours after the infusion. That's the therapeutic role of ketamine, building synapses and dendrites. Each dose is additive upon the prior one. And that's the building blocks of how IV ketamine truly works.
I really appreciate that clarity.
Absolutely.
One of the conversations that I really wanted to have, because again, I do believe in the power of ketamine treatment in in all of the ways that we're speaking about doing it, right? Um, and I probably will just keep reiterating that throughout the
Absolutely.
conversation, just so that I
Sure.
really hit it home with my audience. Like
Uh-huh.
we are talking about a very specific way of
Right.
treatment. But in that sense of treatment, um, ketamine therapy is expensive. I mean, it just is, especially in the places where you're more able to get it right now, which is be the big cities, New York, LA, right? There's not as many options for treatment in the rest of the country
Correct.
yet. Um, so, uh, in talking about who ketamine is um, most useful for, a lot of people with PTSD, with mood disorders, um, especially in LA and New York, are from communities that don't have access to the kind of money that would be required to get treatment, right? So, um, can we talk a little bit about that? Like, what is being done to make ketamine treatment actually available for the people who need it most, who might not be able to afford it?
Right. So, unfortunately, intravenous ketamine is expensive, and that is reality. The reason is that it's not what we call formally FDA approved, as, for example, Spravato, the nasal spray is, which has been through trials and is FDA approved and will be paid for by insurance. We use it off label, but many medications are used off label. For example, medicines for cancer. About a third of medicines are used in the off label sense. The off label designation does not in any way mean it's not safe. Certainly, there's been hundreds of papers published on the efficacy of intravenous ketamine. But the issue is certainly related to cost and economics because it's expensive when used off label. In our practice, we do offer options for first responders for discounts, as well as persons who have served in the military. Um, but also, we do offer, the option of what we call care credit, which is a special credit card where you have up to 2 years to pay off the balance interest free. So that is an option in that sense. But you're right. Look, it is expensive therapy, and that's why we give a patient 6 infusions in 14 days. If they're not going to respond by the sixth infusion, then we don't, recommend continuing. Obviously, people budget their time and money, their energy to go through this. But you know, it's it it's clear that if it's not working, then we wouldn't pursue, or go forward. At some point, it's likely there may be some action by some of the pharmaceutical companies to possibly, invest the money, which could be upwards of, you know, maybe $500 million to $1 billion in the clinical trials for this, drug, which is currently off patent, to somehow make it available and get it FDA approved. I don't see that happening, however, anytime soon. And that makes it difficult because this therapy intravenously is really the gold standard. Intramuscular use certainly is used by many physicians and practices, but it produces this jarring psychedelic state almost, kind of going up and then coming down, which we find is not the ideal approach. Lozenges and sprays certainly can be helpful and certainly options for patients that can't afford intravenous therapy. And that's what, to your point, that's happened is that as a price point and to help patients pay for this, this is where the online and telehealth world has really started to explode and has exploded in the last decade, making it more affordable. But in terms of efficacy, unfortunately, we don't see sustainability in the at-home use of such products, specifically the lozenges that are prescribed by known online providers. And so we don't see this as a sustainable method for improving mental health. Intravenous ketamine is more rapidly absorbed, sustainably absorbed, and it's 100% bioavailable. And because of that, and us being able to control the experience as well, makes it much more efficacious in treating mood disorders and PTSD, which is what our goal truly is. Um, in the near future, it's possible the FDA may be able to get this approved, and make it much more widely available. But we don't see any pharmaceutical company at this point really jumping in to do this, which is unfortunate.
And I would, perhaps I'm wrong, I'm just making an assumption here,
Mhm.
but my assumption would be that they are not jumping on board because it's not actually going to be that profitable for
Correct.
them to do it in a infused manner.
Right. And I think that's really it's profitability, profits really, which is, very disturbing, which is the reality of our current, situation that we live in. And
It
that's
is. It's just
problematic. Yeah.
I find it really problematic and frustrating
Yeah.
because it's it's denying access to people who really need it in the safest way possible, while at the same time promoting the means of addiction and abuse, um, and and, n and even aside from addiction and abuse, just not getting the results that you could be getting. So, you're putting a substance in your body without getting a benefit for it, and still and somebody's paying for it. So it's just frustrating to see the cycle continue to happen, right? Of like, we know what can
Right.
work and how,
Exactly.
and that because we know it can work, we won't fund it because if
Yep.
it works, all of the way that we make money is gone.
Right. Absolutely. We see a lot of patients, for example, that have tried Spravato, esketamine, the S-ketamine. There's an R in S-ketamine, and the S-ketamine is what we call Spravato. That compound was FDA approved in 2019. And what they did was they modified and took away some of again, the properties of hallucinations and psychosis to reduce that. That's why the S-ketamine remains. The R has the sort of atypical or disturbing effects of the ketamine molecule. But given that, aspect of what I described, we still see, I would say, an efficacy of only 40 to 45% at best of improvement with the nasal spray. Often it's erratically absorbed. It may be sprayed into the nostrils and not fully, it may run out. We see some patients with variable responses that are, bordering on sort of psychedelic to those that feel nothing. So we get those patients in our practice that want that smooth, continuous, 100% bioavailability of intravenous ketamine. The studies that were done on ketamine were all done on intravenous ketamine. That's important for the audience to understand, your audience, that really is the most efficacious way and studied way in order to improve mood and function. And the other approaches are just not really in any way approaching the efficacy of IV ketamine. We don't, again, see abuse or addiction in patients who receive intravenous ketamine. And because of that, we find that this is really the message that the public and the world should know. At New York Ketamine Infusions, we have 3 offices across the tri state, one in Melville, Long Island, another here in Financial District in New York City, and also in Westchester, New York, in order to serve our patients. Um, our, our website is newyorkketamine.com. Our number is 917-261-7370, and you can call to speak with any patient care advocate, um, uh, and office person in order to really get an idea about our practice, understand more, And then if you'd like to get an intake, we'll speak to you. We'll get that arranged with one of our nurse practitioners as a first step. And then we'll bring you into our office and spend at least an hour speaking and going over your medical and psychiatric history. Um, it's very important that we understand our patients and make sure that this is the right fit for you. Not everyone should receive ketamine therapy. So that intake process and our in-office meeting are essential to making sure that we understand you, the patient, first and foremost. And that's what Dr. Brooks, Dr. Bornacek, and myself pride ourselves upon.
Well, I really, really appreciate you taking the time out of a very busy schedule to sit down
My
and
pleasure.
talk with me today. I know that my audience is going to get a lot out of this, and hopefully, if anyone's listening and could really use the help, they have the resources now to contact you all and get seen. But thank you for the work that you're doing, and thank you for spreading the message about it as well.
It's my pleasure. Thank you again, Chloe. It's so nice to meet you and really to talk to your audience. And I hope the message does get out in a
It
very, very
absolutely
important way. Thank you.
it will. Thank you so much, and have a wonderful day.
You too. Thank you so much.
Queridas, we made it to one of my favorite parts of each episode, the moment of flow. I love poetry. I love words and rhythm, and how when you mix the two, you get into a beautiful state of flow. And so I want to leave you with that at the end of each episode. So here it is, your moment of flow. Choices: self or others, trust or fear, numb or heal. We choose. The finger of light points back to me. I choose. Who's in charge? The finger of light points back to me. Not fair. I didn't choose this. I wouldn't choose this. The finger of light points back to me. Simple does not mean easy. The simple truth is, the finger of light points back to me. The hard truth is, the finger of light points back to me. Who's in charge? The finger of light points back to me. And I choose. Forward, do not look back. And I choose. The finger of light points back to me.